Welcome back to Jeff Studies Made Fun. I'm Dr. Aishwarya Mukal and this is your second part for Dermatology Important PYQ Images. So we are going to be covering a number of topics over here. The first one is dermatological manifestations. These three are basically drug-related skin reactions. So we'll keep that in mind while studying them. The first one is Stevens-Johnson syndrome. It is a drug-related skin reaction, and there is a slight difference between Stevens-Johnson syndrome and toxic epidermal necrolysis, and that is that the epidermal detachment will be less than or equal to 10% of total body surface area in Stevens-Johnson syndrome. However, in toxic epidermal necrolysis, it has a similar pathophysiology as SJS, but the epidermal detachment will be more than 30% of total body surface area. And both of these conditions, they will be treated in the burn unit of a hospital. There will be debridement done, there will be proper dressing done of the lesions, and secondly, the drug which causes all of this, it has to be stopped immediately. Some patients might even need any kind of antidotes, or some patients might even need dialysis to clear that drug out of their system, so as to reverse the manifestations of the drug or at least make it better. Next one we have is fixed drug eruption. So it is a reaction to a particular drug, and the lesions are present in same place every single time the drug is administered, as shown in the figure. All three times the drug, it causes a perioral lesion in this particular patient. So most likely they will give you the same area with with lesions that are a few months apart or a few days apart. So that is your cue for fixed drug eruption. Next one we have is dermatitis herpetiformis. The pathophysiology of this disease is IgA deposition. So we have four images over here. The first one shows group excoriation of lesions. The second one shows extensive surface distribution of this disease. The third one is chronic subepidermal bullae, and the fourth one is granular pattern on direct immunofluorescence. The fourth one is very important for your exam particularly. It has been asked before. It is associated with gluten insensitive enteropathy, celiac disease. It was the latest question in the June 2024 Fmge exam. Next one, the histopathological characteristic is papillary tip microabscesses. Again, another expected question in the exam related to dermatitis herpetiformis. In the previous exams, it has been directly asked as to which enteropathy or which enteric disease is dermatitis herpetiformis directly related to, and the answer was celiac disease. The next condition here is dermatomyositis. Now, in dermatomyositis, there is an involvement of the skin as well as the muscular components of the body. The first image shows a very characteristic rash, heliotrope rash. The second one shows shawl sign. The third one shows Gottron papules, which are again characteristic for dermatomyositis. And the fourth one shows a mechanical hand, which can be confused with arthritis, but it is not. Gottron papules are different from Heberden's nodes as seen in arthritis. Gottron's papules are more erythematous, and you can see that they are mostly subcutaneous. The next topic is pigmentary disorders. The first pigmentary disorder we encounter is albinism, which is due to the absence of the tyrosinase enzyme, and the defective gene is TYR gene. The melanocytes are normal, but there is a defect in there is an absence of tyrosinase enzymes, because of which melanin production is decreased. So in this particular disorder, there will be severe photosensitivity. We have P-baldism next, in which absence of melanocytes since birth can be seen, and it is associated with forelock of hair. the front part near the forehead of the hair will be white in color, and sometimes the pigmentation will extend to the forehead as well. And normal pigment around the hair follicle can be seen, but the hair itself will come out as white. Pityriasis versicolor shows more hypo than hyperpigmentation. The sensation of the skin is retained. On 10% KOH mount, we can see spaghetti meatball appearance. This is very important in terms of your microbiology. So the fungus in which spaghetti meatball appearance can be seen is our Malassezia furfur. And on under wood slump, pityriasis versicolor will show a yellow colored fluorescence. Pityriasis versicolor is another important topic for your exam. Please note that. The next topic is lentigens. In this, there is an increase in melanocytes since birth, and it can occur on any body part. And there is no increase in size of the lesion. So you cannot confuse it with melanoma or any other lesions which are in which the lesion size increases. Lentigens will appear in one size and it will stay in that one size. Next one is melasma. Melasma is the brown or brownish black pigmentation on sun exposed areas. Mostly it occurs on the face. And secondly, it is known as chloasma in pregnancy. Next topic is Peutz-Jeghers syndrome. It is an autosomal dominant syndrome which include oral and acral lentigens, which is that around the mouth and around the fingers. Black pigmentation can be seen. In this particular syndrome, small intestinal polyps and ovarian tumors that can also be seen. So you can see over here, this is a image of intestinal polyp. There are acral and oral lentigens in here, and this is the ovarian stromal tumor. Becker nevus is an acquired hairy hyperpigmentation on upper arms and trunk. Xeroderma pigmentosum, another PYQ almost asked in every single exam. It is an autosomal recessive disorder in which we can see defective nucleotide base excision repair. This is the defect which is also asked in the exam. And you can see that the child over here this is a characteristic image for Xeroderma pigmentosum. There is a high photosensitivity in the children, like they will have conjunctivitis, they will have anything that is related to photosensitivity will be manifested in a patient of Xeroderma pigmentosum. Another PYQ here is incontinentia pigmenti. The only question always asked is about the Blaschko's lines. It is basically lesions and pigmentation will occur along the Blaschko's lines, and this is the characteristic finding in incontinentia pigmenti. The last topic is dermatitis. The first and foremost thing that comes in dermatitis is allergic contact dermatitis as well as irritant contact dermatitis. So what is allergic contact dermatitis? It is an immunological type 4 hypersensitivity reaction. It has some genetic predisposition and it disseminates beyond point of contact, and the desensitization is not possible. So what happens is the skin will come into a contact of a substance or a trigger which the body is allergic to, and the allergic reaction will spread beyond the point of contact. However, in irritant contact dermatitis, the body will repeatedly come in contact with an irritant. For example, it can be any metal, it can be any detergent, or it can be anything, and it can only form the lesion on the site of contact. This is a major difference between allergic contact and irritant contact dermatitis, and we need to remember that. Irritant contact dermatitis is non-immunological and it is a direct tissue damage. It does not include any hypersensitivity reaction. Directly the tissue comes in contact with an irritant and it will be damaged. And the desensitization against that irritant is possible. However, in allergic contact dermatitis, we saw that desensitization is not possible. Nummular dermatitis. In nummular dermatitis, we can see that there is a as the name suggests, there is a discoid or coin-shaped dermatitis. The lesion will be coin-shaped. In atopic dermatitis, also known as skin asthma, in layman's terms, it is known as skin asthma. It is an endogenous dermatitis triggered by exogenous agent, and it is a chronic inflammatory disease with relapse. In this, you can see a family history of allergy, and it is a type 1 hypersensitivity reaction. Neurodermatitis. Neurodermatitis is also known as lichen simplex chronicus. It is a neurological skin disorder. It mostly happens due to reasons unknown. Basically, it is idiopathic. You can see raised scaly pruritic patches in the skin. So the patches will be really itchy, and there is no certain form of distribution, but mostly it will occur in the peripheries, like on the arms and the legs. Next one is seborrheic dermatitis. The agent of seborrheic dermatitis is Malassezia furfur. It shows a greasy yellow scale and the distribution is in the seborrheic area. Mostly it is seen in scalp. The next topic is pediculosis. Pediculosis is basically lice infestation. Pediculosis capitis, it refers to the lice infestation of the scalp and hair, also known as white piedra. Next one is pediculus corporis. Pediculosis corporis. It is also known as vagabond disease, and the treatment is clot disinfection. Now, in pediculosis corporis, you have to treat the family members as well and the common objects in the house as well, so that the body-to-body transfer of the lice will not happen. Last one is pediculosis pubis. In pediculosis pubis, there is a certain lesion that is very characteristic. It is known as macula caerulea. It is a blue macule. Over here, it is shown as a little blackish pigmentation, but it is called a blue macule, and it is important to note for your exam. And in this, the treatment of the partner is very important, because pediculosis pubis can spread from partner to partner during sexual contact. So that's it for today. That's the second video for the derma important PYQ images. Thank you.